Hey everyone who's joining us, welcome. Welcome to the third California OpenNotes Consortium call. We are live and recording, so anyone who can attend or if later you want to come back and watch our greatest hits, you can. Just want to let you know we're recording. So I'm Liz Salmi. I am the Senior Strategist for Outreach and Communication for OpenNotes, and I am the patient co-chair of the California OpenNotes Consortium.
And hello everybody, I'm Carrie Lippman. I'm a family physician and physician co-chair of the California OpenNotes Consortium. I'm a family doctor from Kaiser Permanente in Southern California, and I was quality improvement physician director there for over 20 years and helped implement OpenNotes at my medical center and in Southern California.
Awesome. Carrie knows lots of stuff. In addition to Carrie and myself, I want to recognize a number of other people from the OpenNotes team who are here today and joining us from Boston and the Pacific Northwest. Not everyone is making an official presentation on today's call, but we're all here in the chat box and in the conversation later to answer questions. And then lastly, I want to recognize all of the new people who have joined the California OpenNotes Consortium since our last call. So welcome, and I'm so glad you're tuning in. A few housekeeping items on our next slide. We have automatically muted all lines as you join. You will need to automatically unmute yourself in WebEx in order to be heard. And then if you want during the Q&A section to raise your hand, you can click the hand icon next to your name to raise your hand, and then Amanda will call on you. And go to like some next slide, next Amanda. Yeah, there you go. And then during the Q&A, you can raise your hand, and then Amanda will call on you. Say hi, Amanda.
Hello.
Thank you. And then we will have a verbal Q&A at the end of today's presentations. So in the meantime, we encourage your conversations in the chat box. So feel free to use the chat box throughout the convening and then send your questions to everyone so that we can all see your questions. You can also post questions for the presenters in the chat, and then we'll be referring back to those questions later after they're all done. And then if someone posts a question that you know the answer to, feel free to respond. We can crowdsource some answers here as well. And then lastly, webcams. You might notice some of us are on webcams, and if you happen to be at a computer with a webcam, Carrie I invite you to join us on your cam. It's nice to put a face to a name or a voice. And then we will send the link to this recording a day or so after this call as we get everything edited down.
And so I wanted to cover some ground rules that we always do. We have a diverse audience of clinicians, administrators, informaticians, if that's the way to pronounce it, health IT folks, patient experience professionals, and patient advocates. So we want to be respectful to everybody. We like to use first names throughout today's call. It can really help level the hierarchy. So I'm Carrie,
Hi, Carrie.
Those with professional titles, you know, we all want to be on the same level. We're all professionals and experts in our different areas. Due to the diversity of our audience and the fact that we have many people representing different health systems, today's presenters will do their best to introduce concepts using plain language before switching to jargon, and we will try to explain acronyms in the first reference. Please feel free to send a chat message in the participants tab if we forget and some medicalese slips in, and because if you didn't understand a word, there's probably other people who didn't also. So we have an amazing consortium call planned. We have a lot of good discussion here. We need to watch the clock, and we're going to be really making sure we're respectful of your time so we end on time. Take it away, Liz.
Awesome. So before we get deep into today's call, next slide, make sure I'm on the right slide. I want to let you know about the next California Consortium call. It's coming up. It's either late March or early April. We're pinning it down, and we're really excited about this. Our key presenter is Dr. Natalie Pagler. She's CMIO for Stanford Children's Hospital, and it'll be her as well as a few other folks from her team, and they'll be talking about OpenNotes in pediatrics and adolescents, so stay tuned for that. What's going to be different about our springtime call coming up is that Carrie and I want to open up the time for even more dialogue so we can learn from each other. So bring your questions, share your innovative ideas, and we want to discuss some of the stumbling blocks you may be running into as far as OpenNotes is concerned. And if you have learned something really cool in your work around either OpenNotes implementation or piloting, we want to, if you want to present something, we'd love to hear from you. And then good news, due to popular demand, we're going to be continuing these calls throughout 2019. There is a possibility of an in-person meeting around OpenNotes in the works. So we're working with our national leadership on what that might look like. And possibly, maybe there will be an opportunity to pilot something cool in California. So as that's being worked out, we'll let all of you know on future calls. Next slide. Because we have some newbies on the call, I want to make very clear what OpenNotes is and maybe isn't. And so here we go. What is OpenNotes? OpenNotes is a national movement dedicated to making healthcare more open and transparent by giving patients access to their medical providers' notes via existing secure online patient portals. OpenNotes is not a vendor product. It is not a software. And on the next slide, you'll see some of the foundations that have funded the work of OpenNotes over the last few years. And now I hand it over to you, Carrie.
Yeah, so we've heard what OpenNotes is. What's the California OpenNotes Consortium? So it's a learning opportunity of California clinicians, health systems, and patient advocates with the goal of focusing on OpenNotes implementation. And we're going to hear a little bit that our California, wanting to make California a leader in being patient-centered and using OpenNotes. We have some good news about that. So let's go to the next slide.
Yeah, I want to say that right now there are 25 organizations sharing notes with patients a la OpenNotes in California. This is a big jump from this time last year. We, let's see, January 2018, yeah, we were at 13 organizations who were doing OpenNotes. And so now we're at 25. And today you get to hear from 2 organizations that just started sharing notes in 2018. So you're going to have a fresh perspective of what it's been like for them. And Carrie, will you share a little bit about our topic for today and the theme?
Sure. So I want to start by, I know that this is the choir. I don't want to preach to the choir, but we did want to talk about kind of some ideas that even for folks who are interested in OpenNotes can be thought of as provocative. OpenNotes is not the typical medicine as usual. Marcus Welby, for those of you who don't know, was a popular TV show physician star back in the 60s. He never shared his notes. He never really discussed things with patients. By its very nature, sharing clinician notes breaks the traditional paternalistic, mystical view of medicine that is controlled only by physicians, is mysterious, and way too complicated for someone without a degree to understand. We know that the times are changing, and for the last 10 years or so, we know that that there's now much more of a patient impact, that things like shared decision making and involving patients in healthcare topics is something that just is now becoming the norm, but it is still pretty new in terms of the overall history of medicine. We look around the world today, we see that there's been changes in so many other areas: commerce, finance, transportation, and just about everywhere in society. Medicine seems to be one of the slowest to change. We're still practicing medicine pretty much the way we did 50 years ago. But in the last few years, that has started to change. We now have medical clinics and pharmacies and retail stores. We have Dr. Google providing latest medical information to just about anybody. And we have 37 million Americans, as well as some Canadians and Europeans, who have access to their clinician notes. So that's really, we're breaking ground here. But we know that OpenNotes implementations often are done with assumptions that certain areas should remain off limits, that we shouldn't really share everything with patients. They're not ready yet. So the most common of these are mental health, psychiatry notes, and pediatric notes. And in addition, we find that most decisions about implementations are done based on what clinicians and healthcare administrators think. Actually, they don't often talk to patients themselves to find out whether and how to implement OpenNotes. So we decided that it would be a good use of this consortium to talk about some of those provocative ideas. We picked listening to the patient voice, sharing psychiatry notes, and some ideas for the future for discussion today, to talk about those who have assumptions and maybe challenge them about expanding OpenNotes horizons. We hope that in the near future, these will not be very provocative.
So each call, we think it's really important to highlight a patient voice. And today I have the honor of presenting a letter from Leah, not her real name, a patient who couldn't be here today, but agreed to let us share her story. Leah did not have access to her clinician's notes, and she sent us a heartfelt letter to the leaders of her healthcare organization to share her thoughts and to ask for OpenNotes. So now I'm going to read this letter, but please read along with me. I think it's a really good one. So Leah writes, Dear Keck Medicine of USC, my name is Leah. I am in my mid-30s and I've been getting excellent care at Keck since 1999. I have the team at Keck to thank for living this long, and I'm writing to you to request that Keck implement OpenNotes. I find it extremely difficult to put into words how I feel about the outstanding care I have received at Keck over the past 19 years. Some highlights include going to college, earning a BS, BA, and MBA, traveling all over Europe and to Asia, and getting married this past year to the love of my life. While I'm living with a disease that is extremely difficult to manage, my doctor and the Keck team have made my journey so much easier. Most people with my condition do not live past middle age, so I am so thrilled to have these extra years, and I attribute all of this to my doctor and to Keck. Why have I lived into my mid-30s? I attribute my good health to the collaborative relationship and mutual respect that my doctor and I have for each other. He takes the time to explain to me what is going on in my body and how to interpret my symptoms, and he takes the time to listen to me when I frequently experience issues that are a bit outside of the norm for my diagnosis. Compliance, both adherence and persistence, of prescribed home therapies can take 4 to 6 hours a day just to keep my body at its baseline. And having the knowledge to understand and interpret my test results, understand why I take each of my medications, and my overall treatment plan greatly enhances my propensity to be compliant with my home care plan. Which leads me to my request of Keck to provide OpenNotes to patients here at USC. I have experienced the benefits of OpenNotes at Cedars-Sinai and UCLA, where I received some care as well, and it's made a great difference in my health. OpenNotes, from my perspective, can, 1, give me the ability to review my physician's observations and the treatment plan to assist me in remembering what I need to keep myself healthy. Although I try to write things down during my doctor's visits, I see so many specialists it can be challenging to absorb everything during my visit. I see a hematologist, allergist, OBGYN, family physician, cardiologist, ophthalmologist, endocrinologist, ENT, psychiatrist, and psychologist. OpenNotes would allow me to enhance my compliance with 11 different treatment plans from these 11 different providers. Even the smartest person would struggle to remember every single detail of their care plan. Give me the ability to more easily share my team of physicians' notes and care plan with each other. Not all of my physicians use your electronic health record. In fact, most don't. So sharing information can be challenging. But my care and avoiding dangerous side effects depends on sharing my medical information, history, and treatment plan across 11 different physicians. As a patient, I need to be deeply informed about the different issues taking place in my body, what my amazing group of physicians is doing to strike a balance, and what I can do as a patient to support this effort. Further deepen trust with my care providers. I have no doubt in my mind that I receive the best care in the nation here at Keck, but being on the same page, per se, with OpenNotes, with my care team here at Keck, would only deepen the already solid trust that I have in my physicians. And lastly, give me the ability to share my care plan with my spouse, parents, and friends who help with my care. It takes a village, as they say, and care with my condition is no exception. The biggest unsung heroes in chronic disease management I would argue, are caregivers. Sometimes I'm on prednisone and can't think clearly, and my caregivers try to know my treatment plan, comorbidities, and other issues to assist me in my care. OpenNotes would greatly enhance this. Sometimes I'm in emergency situations and my caregivers need to help me communicate to emergency room physicians my latest results or latest treatment plan notes from my doctor. OpenNotes would assist in these situations tremendously. In closing, I humbly submit to you my request for OpenNotes to be available at Keck. If you have any questions regarding my request, please don't hesitate to reach out to me. Thank you from the bottom of my heart for your consideration. Leah. Wow.
All right. Thank you very much, Liz. And thank you, Leah. Please pass on our thanks to Leah for sharing that story. I now want to introduce the person who received Leah's letter, Dr. Gil Shlamovitz, Chief Medical Information Officer at Keck Medicine of USC. Gil was instrumental in the implementation of OpenNotes at Keck USC and we'll be discussing the impetus, planning, and outcome of this initiative with many areas that other implementers can learn from. In addition to a very thoughtful and effective implementation strategy, Liz and I were struck by the fact that a world-class institution like Keck of USC was nonetheless very willing to listen to their patients, Leah and many others, in deciding on whether to implement OpenNotes. Gil, please share Keck's OpenNotes story.
Thank you, Carrie and Liz. Before we move on with the presentation, I have to say that Leah's letter touched my heart, and it touched the heart of other leaders who I shared the letter with. Leah is not alone. We have a very engaged, very well-articulated group of families and patients that come together to tell us what they want, what works for them, what doesn't work for them, and we listen. The market in Los Angeles, as you can imagine, is an interesting market, right? Patients have choice, and doctors have choice. And patients absolutely share what works well in one institution with their care providers from another institution. All in all, it helps provide better care and engage better, connect better. Transparency is a value we believe in, and this is a journey. I hope that those of you, and I know that you're on the line or the WebEx, are struggling with change management, right? We all know what's the right thing to do. Please feel free to share Leah's letter with your patients and ask them to communicate to your leaders. It takes a village. It takes many Leahs, and it takes many mindful physician leaders, nursing leaders, and administrative leaders to make a change. And I hope this will be the message of the presentation. So let's move on to the next slide, and I'll try to breeze through them. We are one of two, I would say, leading academic medical centers in the Los Angeles area. We have a university hospital, Keck Medicine, Keck Hospital of USC. We have a cancer center, UC Norris Comprehensive Cancer Center. We have a community hospital in Glendale, California, and we have a medical group that oversees all of our academic providers and also manages about 80 ambulatory locations all the way from San Diego up to Bakersfield in California. We have one EMR. Next slide, please. I would like to communicate or message through this slide that our governance processes and structures are probably as complex as yours. We are not any different, right? Each facility has its own governance structure, and there are some enterprise committees or groups that help coordinate EMR design and content. At the end of the day, in order to be successful, it's our job as physician leaders and hospital leaders to communicate and align everybody towards the same goal. Patients like Leah, and through their individual efforts and through their efforts in what we call the PFACs, the Patient and Family Advisory Councils, and we have one in each facility or under each org, are instrumental in pushing us in the right direction. I also have to say that getting early buy-in from our physician leaders, be them the CMOs of each of the organizations and the chiefs of staff of the different organizations, was also instrumental. When physician leaders hear from their own patients and ask, it's very impactful. Next slide, please. It's a journey. So I joined Keck Medicine of USC after they implemented the DMR. I joined them back in 2015. At that time, we already had a live center patient portal, and selected lab results were already shared with patients within 72 hours. As you can imagine, that selected list of lab results was very selected and excluded what others or some may consider sensitive results, but it also excluded many others. In systems that are opt-in, right, you have to white flag results or result categories that you would like to include. very quickly, as more tests are added to your different catalogs, the system is obsolete. And even if the actual test is not sensitive, just another way to do a TSH, etc., patients will not have access to that unless you use the global level of the hierarchy. My first attempt in making a change, and in discussion with other physician leaders in the organization, we chose to make this gradual and make it comfortable. Within a year of my arrival, we got the right support to start and release all lab results immediately, be it a tumor marker and be it a sodium or a CBC. It just goes to the portal at the same time it goes to the patient. We also decided to start releasing radiology reports and pathology reports. I know we are considered as late members of the OpenNotes family or community, but I would argue that radiology reports and pathology reports are written by physicians and even sharing them for a while. As you can imagine, very quickly, both patients and doctors and office staff and nurses started to ask, why can I get my PSA back within 6 hours of blood collection, and yet for the normal chest X-ray report or the abnormal chest X-ray report, I have to wait 3 days? This type of feedback from both patients, doctors, and administrators led us to where we are today. And back in October 2018, we went full force ahead with global OpenNotes. We're releasing all lab results immediately, all radiology reports immediately, all pathology reports immediately, all diagnostic reports, be it EEG, colonoscopy, etc., immediately, and most clinical notes immediately. Thank you for cheering, Liz. I'm here to share what we learned. Next slide, please. Back in 2016, I believe a year prior, there was a change to the HIPAA privacy law as it relates to CLIA, so licensed labs, basically authorizing labs to directly release results to patients without going through the ordering physician. And these included cancer diagnosis, HIV, etc. This new legislation, as of 2015, made our compliance and legal teams comfortable, making it very clear via the portal, and the message you're seeing below is visible on every portal page, is that patients who are accessing the portal and clicking on a lab test, they're actually making a request to review the results. And they're aware that it's possible that their doctor may not have had an opportunity to review them. This is also communicated verbally with patients when tests are ordered. So if you need this language and want to use it, we're not going to charge any commission, so feel free to reuse it as you like to. Next slide, please. A few technical or configuration considerations about our design. The Cerner patient portal does not allow to differentiate between ambulatory or inpatient results. Talking to some of my colleagues, and I worked previously in an Epic shop, it made our life easier because less things to discuss through. We are releasing everything immediately, whether it be it an inpatient sodium or an outpatient sodium, etc. Next slide. Back when we implemented that, Cerner did not support email notification of patients when a new result or report is posted and is available for them to review. That actually means that patients have to actively log into the portal and see if there are any results for them to look at. Unless me, the physician, send a message to the patient, I may attach a result, and then they get an email notification that they have a new message. But actual posting of results, there is no automatic patient notification. Next slide, please. We decided that we're not going to allow any physician or any group of physicians to opt out as a group. We felt that this is really about the individual doctor and individual patient and individual case. Next slide. This is why it took a couple of years to get the organization ready to turn this on, but I think it was worth the wait. What are we sharing note-wise in the portal? All clinic notes, be it ortho, psychiatry, pediatrics, ENT, anything that ends with a clinic note, immediately viewable once the note is signed. all inpatient consult notes, discharge summaries, ED notes, procedure note, and operative reports. Did I mention that we believe in transparency? And yet we all know that, right, the dirty laundry hides in different places, right? When a patient gets admitted to the hospital, we don't really know what's going on. The consensus was, let's not share the H&P. Daily progress notes in academic and non-academic medical centers. We as providers know these notes. We did not feel like they're going to be very helpful or beneficial, as well as we wanted to allow people to flag notes as secure. If they really think that the patient might be harmed or the therapeutic relationship might be harmed, if direct or easy access is provided to these notes, any doctor can flag any note as a secure note, and it will not be shared. Next slide. I'm not going to go over this slide. I just wanted to share with you that the usual debate supporting transitioning into OpenNotes versus really liking the status quo and opposing the change took place in our different groups across multiple facilities. People need to be heard on both sides, and everybody's opinion is of value, and we have to respect that. At the end of the day, we have one EMR. We have to make a decision globally for the organization. We have to weigh the different considerations. Next slide. A few feedback we got after the October 1st go live. Patients are thanking their notes for allowing them to view their notes. That's the most common response. Patients share with us that they used to really stress seeing that the x-ray was completed, but it's going to take 3 more days until the report is available on the portal. So it really decreases anxiety, be it a cancer patient who is expecting a recurrence finding, or be it a patient who is expecting a normal result. They just want to see the result and then deal with it with their doctor. It's the delay that causes anxiety. Many providers didn't really know what was already being shared, so it was a great education opportunity. Next line. We did not see an increase in requests for medical record correction. This happened before, and we're not seeing increase in cases that are referred to risk management or patient experience as a result of physician documentation. This happened before. We still have a baseline rate. Definitely reduction in phone calls. Is my report back? Is my results back? Et cetera, et cetera. Next slide. All right, we're not going to go over each column. What did we learn? So we see that our patients are definitely reading their notes. So clinical notes, it's the last column, and these are the volumes of notes read. Our patients are more interested in messaging their doctors and care teams. If you look at the month of January, to date, 3177 notes read, and yet we had 28,000 messages sent by patients. 12,000 results were read by patients. They're more interested in their lab results and diagnostics results than in reading their notes. It's an interesting finding, I think. Next slide. We did see a bump in use of secure notes, and I would recommend when you go live, have a mechanism to audit who is documenting in what note type, so you can course correct. We found 2 things in the month of October. As you can see, we had a it's about 800 increase in secure notes that month. 2 things happened. One specialty decided as a specialty, we're going to document everything as secure notes. I'm not going to name the specialty. Many of them just wanted to wait a couple of months and see what happens to their peers. Don't fight that. They will course correct. What else happened in October in California is that the cures requirement took place. That's a requirement for prescribers of controlled substances to query the cures database. It's the controlled substance prescription dispense report. And many of our clinic locations decided to scan these reports as a secure note instead of, we have a document type called cures report. So by reviewing what happened, we were able to quickly course correct. And as you can see, we are back to baseline and even lower than baseline. Good discussions with behavioral health. When should a psychiatrist or a psychologist or a therapist use a secure note versus other types of notes, I think also helped with the decrease from baseline numbers. Next slide. Inpatient progress and inpatient consult notes. So to remind you, we are not sharing progress notes with our patients via the portal. We're seeing slight increase. Again, not surprising. It's where you want to document something that will be easily found by your colleagues and not easily read by your patient, as well as inpatient consult notes that we are sharing with patients immediately. We're seeing some decrease. Again, we cannot force this, right? Most of the people continue to do what they're doing. Small numbers chose to change their behavior. That's okay. Next slide, please. Clinic note volumes didn't really change. The increase in volume is related to a pre-holiday season annual increase in volume of patients, and the decrease in volume in November and December is also secondary to annual holiday variation. Next slide. I cannot explain the increase in phone and personal messages note type. We file them as the same note type, whether a patient sends us a message or calls us, and we document that communication. But the good news, they're regressing back to our baseline, so I cannot explain the 44 to 55,000. Next slide. Huge concern about our patients going to ask us to correct our notes more than they have before. Not really. We went up from 462 to 542, which is not the highest we had before. So we're not seeing increase in error. This is doctors actually deleting or in-erroring a full note. We also did not see a significant increase in modifications of notes. We went up from 3,600 to 4,000, and that regressed with no action. So I cannot explain this. Is this just related to the increase in volume of visits or actually to open notes? I cannot answer that. Our organization is comfortable now that we didn't see any much negative effect, only positive from the transition. Next slide. Okay, what's next for us? Marketing. This was a soft go live for us, meaning patients just saw a new section on the patient portal. We did not make an announcement to patients. We did announce this to staff, of course. We're moving forward with both internal and external communication, as well as some portal announcements to make it more known. Still getting up to 4,000 views a month. I think it's a good volume, even without marketing. Adolescent patients, right now, from the age of 13 until 18, neither patients or their proxies can access the portal. This is all going away probably next month. Policy is still making their way up the governance groups, but we will allow adolescent minors to access their own portal. And we will ask these adolescent minors to authorize any proxy access to their account, meaning if a parent wants proxy access to an adolescent account, that adolescent will need to sign an authorization form, unless the child is disabled and cannot participate in that conversation. This may be provocative, but we are heading there. Thank you. I'll take questions now later. Wow,
that's very transparent. Thank you, Gil. So we've got a ton of questions coming in on the chat box, and we're saving them for you to do at the big Q&A at the end, or you can start responding to. But now I want to introduce our next presenter. So excited. Steve O'Neill. Steve O'Neill is the mental health liaison for OpenNotes. He's also a Boston Red Sox fan. Steve is the social work manager for psychiatry, primary care, pain management, and infectious diseases, as well as the associate director of the ethics support service at Beth Israel Deaconess Medical Center in Boston. In addition to that, Steve is a clinical instructor in the Department of Social Medicine and a faculty associate in the Center for Bioethics at Harvard Medical School. Steve's presentations and experiences about sharing mental health notes is one of the most sought after presentations about OpenNotes today. So I'm excited that he's here joining us. So Steve, take it away.
Great, thank Thanks, Liz. So I'm going to be talking, my role, which Liz described, is I oversee all the behavioral health and mental health practices at our institution here. So we're a large urban center that draws a huge population from all around the Boston area. But it's also, I will mention, my background is not just as a clinical social worker, but also in bioethics. That in 1998, when we started an ethics program at our hospital, we had in our program, we made all of our consultations immediately accessible to any patient or family member involved in an ethics consult. And from that experience, that really paved the way for me to be really moving towards transparency in that way. And I will say, kind of in the heels of what Gil was mentioning, that when we started opening up our notes in ethics, we found there was a 50% decrease in phone calls to our legal department for the first 2 years that we started this program. And I think a lot of it was because we were heading things off at the pass and finding ways to collaborate and partner with patients and their families around highly charged, often litigious kind of situations or potentially litigious situations. So we've moved from there. And I think that's a little of where a lot of my staff have kind of ascribed to the notion of opening up notes in this way. Next slide, Amanda, you could. Thanks. So I have no conflicts to report. Next slide. So this is really about 5 years of impression. So the very first mental health notes really in the globe were opened up at our hospital at Beth Israel, which is one of the first centers that opened up medical notes, back in 2010. And then we went live 2014 with all of primary care and then all of the specialty services. And we had the option of adding behavioral health and mental health and psychiatry and social work. We decided that we would open up our notes in conjunction with that rollout as well. And I would think for those that are in the behavioral health area, to think about this as it's another form of narrative therapy. And if you think about Leah's example, I mean, that wonderful letter that was shared, that her ability, if we sequestered those notes, she's seeing, and by her own letter says she sees a psychiatrist and a psychologist. And why would those notes be any less available, or should they be any less available to her than they would be for all the other services that she sees? And that's part of where we're trying to think about what we're seeing 5 years now of experience down the road. And that's what I'm going to share a little bit about the implementation process and what that's been like. Bottom line, I will say that, in fact, actually, all the fears that staff had, all the anxiety that they've had, the anxiety is still there a little bit, but I would say basically it's been remarkably quiet, both here at Beth Israel as well as around the country for places that have opened up notes. So next slide. So we were asking the same three questions that basically were on the medical side. Would open notes help patients become more engaged? Would it be the straw that breaks the therapist back in terms of more work burden? And after 1 year, would patients and therapists want to continue? Same things. So next slide. And we always start with what is best for the patient. And I think a lot of the problem we have in healthcare is many of the systems we have are really provider-centric, not patient-centric. And so this is really, as Liz mentioned at the outset, patients have a right to access to their record, and all we are really doing is just making that access easy and available for them. And I would add, if you think about Leah's example, there's a rule that we use. It's a 70-30 rule. That when a patient comes to a well visit, when you go for a good physical exam, when everything's going fine, the rule of thumb is that generally patients remember about 70% of what's told to them in the session or what's talked about there. That still means they have huge gaps and miss a lot of what is there. So if they can look back and see what was there in the note, that really helps them. And then you take patients where there's a lot of high anxiety or there's bad news being delivered. How much does somebody take in there? We know that generally patients will report to us, and the literature shows that they only remember about 20 to 30% of what's there. So that's the flip of the 70-30, if you will. So this is really, I think Open Notes is really about what's best for the patient and moving the dial to really engage them more. Next slide. So back 5 years ago, we started in both psychiatry and social work, and we had I started psychiatry, did it as a 10 patients apiece, and then ramped up eventually. And in social work, I gave staff the option for they could opt out altogether if they really felt uncomfortable. They could do a ramp up model, just similar to what psychiatry did, where they tested it out with a cohort and then built up, or they could do a full on, just open up all their notes altogether. And we did it not retroactively. This is from the start date of that we had from either March or April 5 years ago. Next slide. We had 15 psychiatrists and therapists in the psychiatry department, so we started with only the faculty. And then we had 29 social work staff who agreed to the pilot. 5 were in, to be tested out. 5 declined. We did not include pediatric therapists. So for the purposes of this is really around adult and ambulatory care. So we had 24 that participated. Right now, we have better than 4,000 patients that are participating in open therapy notes. So that's over the last 5 years now, and that's what we have currently existing. Next slide. These are the fears. You can imagine the fears that would be in any place, right? It's going to increase the work burden, the feeling a sense of pressure to get my notes entered in a timely manner so that they can be useful to the patient. And for me as a manager as well, that to me is actually, I want my staff to be a little bit anxious about getting their notes in a timely way. So that's a pretty good thing for administration, et cetera. Then there was the worry about misunderstanding. I'm concerned about patients misunderstanding information in the notes. And then on the other hand, I'm hopeful that the open notes may actually enhance the therapy process and promote greater communication and understanding at both sides. Many therapists reported that they were worried about patients reading the notes alone. And so, not having a place to process that if they didn't understand things. And all of that will be addressed, and I'll tell you a little bit about that. Staff were also worried that they're going to have to re-language all the notes, then because patients will be angry about certain content, and what's going to happen when they don't have a place to deal with that. And there was a lot of worry about severely mentally ill patients, particularly those that are psychotic or paranoid, that they will flee therapy. It'll have a chilling effect. And we have none of that's been borne out. It's a quote here. It's one thing to tell them in a session that we think they're having a paranoid thoughts, and another for them to read it at home alone. Next slide. We did exclude domestic violence patients because of the safety exclusion, but that's generally true in all places that we tend to not, most domestic violence programs or violence prevention safety programs usually do not do build for visits, partly because if the perpetrator for that happens to be the healthcare subscriber, they can get a notification that the person is seeking services, and just the seeking of services can at times increase the risk for that person. So most all programs kind of eliminate domestic violence, but we've also dealt with that on the side for those patients that end up in therapy that come in with one issue, and then we find that there's something else going on there. So you have to think about carefully documenting those aspects. And we always have to think about, who's the note intended for, who's going to read it, because we have to we get audited as a teaching hospital. We get audited routinely and regularly by our insurance companies and by Medicare. So we have to think about both making sure we've met our standards, but we also document both for ourselves, for our patients, and for any of our covering staff and the emergency department if our patients end up there. So we had a lot of worry about obsessive patients who, the quote I think about, I've spent my whole life learning not to double think. When I go to the mechanic, I don't want to look under the hood. Same here. And that's, so there are patients where, we know that they had simply chosen for good reasons not to look at the notes. And that's okay. So we have to kind of respect what they would like to do and what feels best for them. And then paranoid patients, I'd be petrified to look, and I'm not going to do it. And I will say, that is a quote from one of my own patients, and that patient took him 2 years to be able to look at the notes. He was scared and silly that I would have written that he was a horrible, nasty person. And when he finally read one of his notes, he saw that it was not what I was focused on. That I focused certainly on the struggles that he has, but also on all of the good attributes that he does have and his resiliency. And that was really reassuring for him because he was sure that I would just replicate what his family has always told him about how horrible a person he is. And then we have patients that they can't quite read the bottom part there. having trouble reading that. Oh, in denial, that they, yeah, in denial. If they read their diagnosis and see that, would they be upset about that? And I think generally what we've been finding certainly is that patients, know their diagnosis, they can see their diagnosis, and they have a right to that already. So by not sharing that, the diagnostic impressions, we're sometimes leaving patients in a little bit of a loss. And I think there's ways to do that where we share with patients. Like I think about a paranoid patient of mine who was his view of what was going on, a very psychotic patient actually. What I simply write in my note is I show him as I write down his view of what's happening, and then I write down what I believe is going on. And most of my paranoid patients feel that that's very respectful, that I've captured what they want, but I've also included what I think is clinically going on. Next slide. So when we had this, we started a social work therapist work group we had with all the therapists getting together because we were worried we were going to have a thesaurus for altering our language. And we had developed frequently FAQs for all of the staff, including the front desk staff. We have to make sure because many of our patients would approach them, and our front desk staff needed to be on the same page with everyone. So we did FAQs for the therapists, for the front desk staff, and for the patients that we distributed. All of that, by the way, is on our website and under the mental health section in OpenNotes, and you can download that anytime. And as Gil mentioned about plagiarizing anything we have out there, you can just plagiarize away if it's helpful to you. So we had to anticipate all the reactions and the feedback from patients and colleagues and staff. That work group disbanded after 2.5 months. And what they found, the reason was that they found they did not need to do a thesaurus approach and start to alter the language. Many staff do report that they sometimes used more plain language, that there were some issues, but what most of us found was that we started to write our notes better. They were more readable rather than just clinging to some of the language that we sometimes get taught in schools that are sometimes we want to show off our acumen in that way. So I think our notes are actually better. They're more readable for all of our for the other disciplines as well. So that's all part of the aspect of that. When this first came out, we had a lot of publicity about opening up the mental health notes, and predominantly, close to 90% of the feedback that we got from when articles came out about this was that we were ruining psychotherapy, that we were really messing up the fiduciary relationship that we as clinicians have. And I think what we're seeing across the country now with some of Steve Dobsha's work at the VA, where they've been studying the effects on mental health, and our own work and research on this area too at Beth Israel, we're seeing just the opposite. We're not seeing any of those effects. There was a lot of criticism. This was only helpful for high-functioning, well-educated patients. And we find that, in fact, actually a lot of our patients who are more frail in both psychiatrically or medically, they use these notes a lot to kind of remind themselves of what they're trying to do and what they're trying to work on. I have a couple of patients of mine that routinely print out my notes after sessions. They put them on their refrigerator or somewhere in their house. And they look at that as a reminder of what they're supposed to be working on. So it's kind of the Linus's blanket that they get to take with them wherever they are. And that's been quite remarkably helpful. Next slide. So what we found, patients were very pleased. 90% of our patients agreed that opening up therapy notes is a good idea. Better than 85% of patients want to continue having their notes available. And very few said that it made them feel judged, worried, or offended. Now, if you look at those numbers there, like less than 15% felt judged and then worried and offended. Those aspects, there were some patients, and if you think about the way that therapy works, there's always that in the beginning of any therapeutic relationship when it's first starting, patients always worry about, is this therapist going to understand me? Are they going to appreciate my aspects? What am I going to do with all of that? And will they really see that? And what patients really are telling us is they're looking for a concordance between what we say in the office and does it match what we've written in the note? And when the patients can see that what we've written in the note matches what we've said, that is really reassuring. And if there's not concordance, that's when the patients actually feel a little bit more judged or worried. It's kind of like what happens on the medical side when physicians or nurses write that somebody is struggling with morbid obesity, and the patient never heard that term. They'd had discussions about being a large person. And, it's when you explain to them that you have to use that term, as offensive as it is, because it's for billable reasons. It's actually for auditing reasons. They understand that. So if we're just transparent about the reasons why we're saying something, that's what's really helpful. And that really helps them to feel more respected and I think collaborative in that way. The adverse effects that we thought would be there have just not materialized. Most of what we've had in our system, our notes are integrated. They're right in the middle of the medical record. So our notes you'll find them in the medical record. They're not in a separate system. So if I was seeing one of Kerry's patients in his practice, my notes would be right in there with the primary care practice in that way. And, that most patients more worry about not open notes, but about privacy, about who gets to look at the issues that they have. That's actually more of an issue in that regard. And then sometimes what we found is that patients sometimes misinterpreted some aspect, but that's important for us to then just be able to clarify that. And again, as I mentioned, concordance was the other really big issue. Next slide. So the vast majority of patients never mentioned to their therapist about having read their note, and the therapist never asked the patient about if they had read their note. This is a study that we're about to publish about this. And what's interesting about that is in therapy, we generally train, most of the therapists, we're trained to kind of wait for the patient to ask about something. So it was kind of ironic that here we open up this whole program and the therapists are waiting for the patients and the patients are waiting for the therapist to say something. So we think there's a little bit of a missed opportunity on both sides there. And I think that's incumbent for the therapists that we need to change the way that we approach that in that way. There is a reading rate drop-off that is different than on the medical side. And I think that that's really largely due to the redundancy of our notes. A lot of our notes, particularly for ongoing therapies, are pretty redundant. So it's not surprising that a lot of our patients read them a little less often after that. Next slide. So, and most practices always worry about the nightmare patient. There's always what I found in our own practices here is that some of my staff were talking about the nightmare patient. If we open up their note, it's going to be horrible. These are labor-intensive patients, no matter what you do. And so this is, so I don't think it really changes that aspect. And in fact, they became contagious. A lot of my staff were talking about the very same patient, some of which was not theirs. They weren't involved in it, but that was the worry that they have. But it doesn't change that. And I think we have to study a little bit more whether in fact actually it might mitigate some of the labor intensity for them. Next slide. So it's really a contagious, and next slide, yeah, they're respected. So this is better than 50% felt more in control of their care, better at self-care, better at remembering, more engaged, and better able to trust their therapist. So we think this really, opening the notes on the therapy side really launches them in that way. Next slide. So they wanted to continue, and they felt it would, interestingly, would affect their future choice of therapist. It would be affected if they were a choice between an open notes therapist and a therapist who's not participating. And not one therapist or patient has asked the staff, and all the rest of my staff have asked to join, except for two who are very close to retirement and just asked them. They don't want to be bothered with that, but that's it. But everyone else has opened up, and they're fully opened up now at this point. The other aspect about this is the stigma. If we don't open up mental health notes along with the other notes, we usually do because we say the patients can't handle it. And I think our patients are showing us that that's just not true. And just as Gill opened up at Keck, opened up their program to include the psychiatry and psychology and the other mental health and behavioral health notes, that is really admirable to do that because it's a hard thing. There's a lot of pushback on that. But I would say if we don't do that, it just enforces the stigma that this population can't handle that when in fact they're showing us just the opposite. Next slide. I'll stop there, and that's for questions. Thank you.
Carrie, you're still muted.
Thank you. I had to stop and put on my sock, and you knocked my sock off there, Steve. That was really great. So I think that's going to help show people that what's provocative doesn't have to be. We're now going to move on to our last speakers. We have two OpenNotes implementers from UC San Diego Health. Dr. Marlene Millen, the Chief Medical Information Officer, and Dr. Chris Longhurst, the Chief Information Officer and Acting Chief Medical Officer, and they're going to discuss their OpenNotes implementation. Marlene and Chris will share how UC San Diego moved their implementation forward and also talk about some provocative ideas for the future of OpenNotes as they see it, and patients' access to information in general. So, Marlene and Chris, we're all ears.
Hi, let me know if there's any trouble hearing me. So my name is Marlene Millen. I'm the CMIO for the ambulatory side at UC San Diego, Chief Medical Information Officer. And I started about 2.5 years ago. You can go to the first slide, please. So what I want to do is kind of go through our journey. We started kind of, you know, at the beginning, I'll say, with sharing patient data. So when I started as CMIO about 2.5 years ago, I'm a primary care internist. I actually do a lot of different types of patients. I do a lot of end-of-life care. I do a lot of psychiatric care. And I'd always personally sent information to my patients. I've always sent their, you know, their results. I've copied and pasted their radiology. I've printed out their notes. I've, you know, discussed with them specialist notes and given results, lab results as much as I could. And Chris Longhurst actually invited me to become the Chief Medical Information Officer. And when I started, UCSD in general was only really sharing certain types of labs and then only at 7 days. So we weren't actually really sharing a lot of information with patients. And one of the distinct memories I have about when I started was Chris kind of met with me after a Gemba round that we had and said, hey, have you heard of this thing called OpenNotes? And I was like, no, what's that? And then he said, hey, it's sharing your notes with patients, and isn't that great? And I said, yeah, that sounds really great. And then I remembered where we were at UCSD, which is not quite, you know, even sharing like, you know, radiology and things like that yet. And also, I personally, as a doctor, I'm always bad with my right and left. My patients are kind of famous for having to wait at radiology to get a call to me to switch to radiology. So I was like, oh, do I really want them reading my personal notes where I've made, you know, maybe a right-left error or, you know, didn't write something as clearly as I should have. But I think that conversation with him sparked something in me where I was like, hey, you know, I'm worried about that, but I already feel like patients should look at their information. For me, it's helped with the care. A lot of primary care doctors were doing what I was doing, which was sharing as much as we could with the patients, and we knew it helped with the care. Go ahead and move to the next slide, please. And so one of the things as taking on the role of CMIO, rather than jump right into OpenNotes, which I, you know, was a little leery of at that point, but realized we had a lot of work to do just to start sharing information and moving ourselves forward with, you know, giving information directly to patients. So we started, you know, just the similar things that you've already heard in earlier talks, but we really tried to start releasing things more quickly to patients, you know, more types of labs, move the time frame down from labs to within a day, and then including hospitalized patients. And then in addition, we, about a year ago, started releasing normal x-rays at 7 days. As part of that normal x-rays, we also found like sometimes the radiologist thought it was normal because, you know, the patient already had metastatic cancer, but they would say worsening. And so patients were getting information sometimes through release of information or release of the radiology and things that actually moved us forward for discussing like what should patients see, how quickly should they get results and things like that. Next. That was our app, by the way. And then one of the things is with Tom Savides became our lead patient experience, which we hadn't really had that role here at UCSD. And having a physician champion outside of IS actually started to help with releasing information to patients. And he actually became a big proponent of OpenNotes. I'll let Chris go ahead, next slide, please.
So as Dr. Millen said, she's been in the CMIO role for about 2.5 years, and I came here about 3 years ago from the Children's Hospital at Stanford. And in fact, I know next month, Natalie's going to be giving an update on OpenNotes at Stanford Children's, which was an initiative that I helped to start before coming down here. And so my previous experience really informed me that, you know, this is not a technology project. This is very much a change management project. And so we did some brainstorming internally on how we could really launch this initiative from a change management standpoint. And at the same time, of course, Dr. Del Banco and colleagues from the consortium in Boston have been sharing some terrific publications. We know that publications in the peer-reviewed literature and data speak to our faculty members, And so we arranged for Tom to come out and give a grand rounds in the Department of Medicine. Fortunately, he also brought Liz from Sacramento, who was a wonderful addition. And we took advantage of having him on site to not only give a talk to the Department of Medicine, but we had him give a open talk that we invited faculty from other departments, the Information Service Department as well. And then I also was able to sneak him into our executive team meeting. And I'll tell you that that was really fantastic. Tom and I had a great time, and Liz, with the execs. And he gave sort of an abbreviated, I'd say 15-minute version of the talk. And by the end of the talk, our entire executive team, many of whom get their care here at UC San Diego Health, were just sold. And our CEO actually asked the question, why don't we just turn it on everywhere at once? And we said, well, let's back up. And so we'll take you through the journey that we've been on. But having that executive support in the background has been phenomenal as we've run into faculty resistance and concerns.
Next slide, please. So one of the things that came out of that talk with Dr. Delbanco and Liz was actually realizing how often they went into their own charts too. I thought that was an interesting thing, reading notes and then also wanting to see their results right away. So what we did to kind of do the next stage of trying to get us ready was start talking to folks in different departments to see who was ready to do automatic release. You know, Chris really understood how important that was, and I did too, in order to share so that you didn't have to hit a button every time. Our primary care attendings actually were very enthusiastic about it, and our whole entire primary care department automatically shares notes. There was one provider I know that always unclicks it, but after about 2 weeks, she started forgetting and realized nothing bad happened. So she sent me a note and said, hey, I'm sharing my notes now also. And then we had other areas. Urology was a big area here. Some areas in oncology are sharing their notes automatically also, meaning that they don't have to click it every time. And then we have a lot of physicians that are sharing that set up to share in neurology and GI. The interesting thing for us is we share our instance with UCI and Community Connect. And when we turned this on, we had to let them know we were doing this. They weren't quite as far along the journey as we were, but them having access, I'm hearing from physicians in those areas that they're actually automatically sharing notes also. So by kind of getting ahead at UCSD, we're actually sharing it in other places also and moving them along. Next field. So one of the things that I was kind of expecting was a lot of phone calls and issues about mistakes. Anyone who's on Epic knows it's a little bit hard to find the notes. In fact, when we went live and I figured out where it was, I went on my kids are over at Rady's here in San Diego, and they're actually doing open notes and hadn't really advertised it either. And I was like, wait, I can read all my kids' notes. So it was a really cool experience for me as a patient and a user of the health system too. So once, we went live, we were expecting this big storm coming at us and big issues. Excuse me. But, there really wasn't much. I got a lot more emails from physicians kind of who, were reading the email about the announcement and the next stage. My favorite, I think I was called having a moonbeam notion for trying to share patient data with the patients directly. I had a very nice conversation with that person, and I actually brought them over to understanding why patient data is so important to be seen by the patient. So even anything that was might be considered negative, I used it to kind of get the person to kind of see the patient side of things. And then we actually started sharing a lot of notes that were a little bit disappointed when we went and looked to see who actually read them. And, first month we only had about 70 people. And so one of the things we found is, just like me not knowing, is that it's not very obvious in Epic where it is. And so the good news is with the upgrade that we just moved to the 2018 version, and without even really changing anything else, our read rate did go up quite a bit to 300, excuse me, a month. And Epic's actually coming up with some more updates. We were just on a call a short while ago to see some newer features that are going to have to make it easier. We were alerting patients. We were including it in their after visit information and things like that. I did hear feedback from patients. They are reading them and they really enjoy that. But the other interesting part is, like was mentioned earlier, is that it's some patients don't want to look. They don't want to read the note. So I thought that was interesting too. But the ones that, especially my really sick, multi problem patients, or ones that go different health centers are really enjoying it. Next slide, please. So, one of the spots that we're at now is, it's been quite a few months that we've been on, and we're going to be approaching the 1-year mark in May. And I'd really like to move forward with sharing all of our notes. So one of the things I wanted to share with this group is just kind of what we're thinking of doing to kind of spread this further beyond the folks that are currently automatically sharing. And so one quick story is that we actually, in the fall of 2018, we started sharing all radiology, not just the x-rays. And that actually brought up some really interesting discussions because we started sharing PET scans and CT scans. And oncology brought up a really good point for themselves because they discussed this internally, like, hey, when we release a note, patients have already been talked to and seen. But the radiology, we need to call them beforehand before we release it. So actually releasing notes is almost easier than radiology. So it was a really interesting feedback from them, and it actually helped move the discussion along about OpenNotes. And so we're going to be targeting early summer, and part of that is Epic is going to be updating and making it even easier to see notes. So we don't want to, we want to try to get more folks on it before that becomes easier so that people are kind of used to it. And what we're going to do is have we have a bunch of doctors that work in the IS department here, and they're starting to give regular talks, and we're going to have them talk also and get feedback and kind of hear what people's concerns are. And so we did this a little bit a while ago for our upgrade, and that actually went really well. We got really nice feedback, and it was great to be on the ground. So having them, be heard and hear how supportive our administrative is firsthand, because we all know people don't really read emails, I think will be really helpful. And then we're lucky, like, as Chris pointed out, we have very good support of our patient experience CEO and our physician group to kind of move forward with OpenNotes. Next slide, please. Chris is going to finish us off here.
So I was just looking up that Moonbeam email, and it reminded me that the initial announcement about OpenNotes actually came out from our chief executive officer and our chief experience officer, which I think was exactly the right message, that this was about patient experience and it was a health system initiative. So a couple things that we're working on as we look towards the future. The first is that, as Marlene suggested, Epic clients could be easier for patients to get access to these notes. So we've really been pushing the Epic development folks along with some colleagues to ensure that the next version of their mobile app highlights it. And we've actually been confirmed that we will have control of iconography, so we can put the OpenNotes icon in the mobile app. The second is that we were early adopters of the Apple Health Records initiative, and actually just published some of our early results last week. And one of the questions that comes up from reporters and others is, are the notes available in Apple Health Records? And the short answer is that they are not yet. And that's not because of Apple or Epic. It's actually because of the FHIR standard that creates the interfaces between the two. And so the Argonaut project, which owns the FHIR standard, has defined a new version to include notes. And we're working with both Apple and Epic to try to get that moved forward. There are some interesting concerns that it's raising when patients not only have access to their notes, but have ownership of their notes and could share them elsewhere. And I've pointed out, as have others, that they certainly can today with a simple copy and paste. But another round of some similar concerns that we'll be working through, I think, in the coming time. And I'll leave with sort of this question. Liz asked me provocative. What might that enable, that you actually could download and own your own notes and keep them with you and not just access them through a patient portal? So thank you. Looking forward to the Q&A, and appreciate everybody's time. We've got our both of our email addresses there, as well as Twitter handles, and we look forward to hearing from the community.
Thank you, guys, and thanks for these great photos of San Diego, California. Thank you to all of our presenters. We are now turning to the most exciting time of this call, and that is Q&A. So for those of you who've been listening this whole time, make sure you, unless you're ready to talk, mute the bottom of your screen. So if you scroll down, move your mouse to the bottom of the screen, and you hit the mute button, because we're about to unmute all of the lines. This is a wild proposition, a provocative idea on its own. So Amanda is going to try to unmute us all, and if we hear a bunch of noise, wild background noise, we might remute you, so give us a second. But whoa, Amanda just unmuted a whole bunch of folks, and I don't hear all kinds of noise. So I'm just excited. So at this point in time, if you want to ask a question, you can just ask a question, or you could raise your hand in the participants area of WebEx. And I'll turn it over to Carrie to start the Q&A and lead us through it.
Yeah, I think we had a couple of questions that had really good answers on the chat function. So those of you who had questions, Deb Washington gave information about pediatric notes, adolescent notes. There's some good information about behavioral health notes, and also about how to prepare doctors. So based on some of the questions that we had. Deb, did you want to add anything besides those great links?
Just there's a lot more information on our website, so feel free to look through there and also reach out to Liz or any OpenNotes staff for any more information you might need.
Yeah, and somebody asked if we were going to be sharing the presentations, and the answer is yes, as well as a lot of other great information. Liz, when do we send those out?
We're recording this call. Amanda is going to take the call and chop it up per presentation, which gives her a day or two. So whenever, no pressure, Amanda, but whenever Amanda's done with the editing of the video, we'll send an email out with links to all of the videos, a PDF of all the slides, as well as links to resources mentioned during this call.
Great. Any questions? What's the top burning questions out there?
Can any of the presenters speak to experience with non-English speaking populations?
That's a great question. We had a discussion about that in the last consortium call. If you remember, we had Anshu Abhat talking about using OpenNotes with kind of a variety of populations, and we have that link to her talk, as well as anyone. Gil or Marlene, anything you wanted to share regarding language appropriateness, language?
Yeah. Hi, it's Marlene from San Diego. So we are definitely, our MyChart already starts with some language limitations. We do have a lot of caregivers that are on the MyChart, and we of course have proxies. So I have a lot of Spanish. I actually speak Spanish, so I have a lot of Spanish-speaking patients. And my notes, of course, are in English, but actually one of my better readers of their notes is a Spanish patient and their family, because they can't always all be at the clinic. So it depends, I guess, how you have your MyChart set up. But of course, remember, it's not, your notes in English. So there is a translation level there. But as long as they have MyChart access, we have a Somali patient, we have multiple different nationality patients that we share all their notes in primary care.
So this is Steve O'Neill. So I just would add one other thing with a lot of our non-English speakers. It's always been an issue in therapy, just trying to do therapy with an interpreter, and it works. We make do with what we have. I would say there's one other aspect of all of this that actually has been helpful for a subpopulation, and I think you probably have a much larger population there in California than we certainly have here in the Boston area, and that is some of our non-documented persons that we see. If they have to leave, one of the advantages of OpenNotes is they can, if they move someplace else or they have to, uproot themselves or whatever, they can access their notes no matter where they go without having to then leave an address to have a medical record forwarded. So there's a little bit of an effect, I think, that's really been a blessing in that regard.
Yeah, I can comment that our portal allows patients to choose their primary language of English or Spanish. What it does, it changes the headers, the links, and the subsections information. The actual radiology reports, doctor notes, lab results are in English. That's how they're stored in the medical record, and patients receive exact copy of them. What do patients see in the patient instructions? So when they look at the visit summary, that depends on what their provider entered into the document. So English and Hebrew, primarily speaking providers like myself, will use these languages. And if someone wants to enter a Spanish or any other language, they will either use an interpreter. I know that some even use Google to help with simple translations, even though it's not certified, but patients will read what's posted for them, and that's up on the provider to determine that.
Gil, since you're talking, I think it was Miriam asked the question. No, I'm sorry, Amy asked the question. Can secure notes be accessed by patients via a medical records request? Right. So a secure note in Cerner is not a metadata on the note itself. It's an actual document type. And what most organizations do, they exclude this document type from the automatic release of information. So to understand the process, patient requests a full copy of the record. There is a template that will pull in progress note, admission H&P, discharge summary, lab results. It doesn't automatically pull into the PDF they get anything that is filed as a secured note. That requires manual review by medical record staff that have to follow federal, state, as well as hospital policies and regulations in determining what content can be shared with what recipient. Patients have the right to receive a full copy of most of the information. Typically, secure content may require additional authorization. If it's behavioral health notes, they may require the therapist or the psychiatrist to authorize the release, and 99.9% it's going to be authorized. There are different types of content that may be filed as a secure note. It just says that there is a human being vetting what will be shared with a paper-based release. A question that came in from Miriam, and this can go to Gil, Marlene, Chris. She asked, was there any training for providers on what not to mention in the notes before going to OpenNotes, or just general best practices? So the OpenNotes website, and there are other resources with some generic recommendations that I think will help everybody. I used to tell my colleagues, I still do that, write it the way you want an ER doctor like myself, right, will understand. Don't make it more complicated than what I can understand so your patients can understand that. These guidelines or some documentation recommendations were shared with every memo that was sent out, sharing what Marlene said, that not everybody reads their messages or memos from the CMIO or the CMO or the CIO. We took a long time to communicate. The communication came through department chairs, clinical department administrators, chiefs of staff, chief medical officers, myself. So just repeat messaging. We also held several Q&A sessions in each location. We had participants from risk management, legal, medical records, patient experience, informatics, brief presentation of recommended language, what to say, what not to say, focus on the mechanics. How do you choose a document type, or how do you choose a secure note type, and then Q&A sessions to allow the different providers to learn and ask questions. We also had similar sessions with staff, because as you can imagine, clinic staff and hospital staff have questions and interact with patients a lot. So we wanted to make sure everybody understands the mechanics as well as what to do.
So hey, this is Marlene. I'm impressed. That's a lot of help. We didn't get quite as much at UCSD. We did create a website that we advertised out that had great links. We definitely utilize, and I highly encourage everyone to utilize OpenNotes content. It's wonderful. There's great videos, and I think using that and creating our own website where we can link it really helped. We created a tip sheet for the Epic side just so people knew, it's pretty simple, like here's a picture and here's how you unshare the note when you don't want to share it. So it was pretty straightforward on there. And then in the primary care areas, which were automatically sharing the notes, we did, I did come and give talks to a couple of the areas. And the basic thing I said is, don't write anything in the note that you wouldn't tell the patient. And if it's something that you do need to write that you don't want the patient to see, then don't share the note. But, I have patients I think I use the keyword talkative. So if you see that, you'll know our secret word. And that just means the patient might be a little bit, hyper or manic or something is a little bit different. And that helps me or other docs know a little bit that, if the patient has like psychiatric illness or things like that, I'm going to tell them. If they have alcohol abuse, I'm not going to put it in the note and not tell them. So I think one of the things that we concentrate on is just making sure you communicate what you have in the note. We didn't really tell people to write their notes differently. We just worked on the communicating what's in there. And definitely big thumbs up on the OpenNotes website.
Amazing. Is anyone raising their hand in the WebEx that's waiting to be called upon?
I don't see any raised hands.
If there's anyone with their audio on and you just want to ask a question, that's totally fine.
There's really great questions and really great answers in the chat function. And I think, Liz, we need to share some of these great links. So I think we'll talk about a way so that I think it all goes away once we end the call, but there's really some invaluable information there.
Absolutely.
There was some discussion about adolescent.
Hey, this is Anshu from LA County. I have a couple questions. So this is really great. Thank you, everyone, for presenting. One question was on the mental health side. Do you have recommendations for facilities who are not live with mental health? So, for example, in LA County, that was one thing we couldn't really convince providers on when we went live last year. So do you have any advice on how to then restart that conversation?
So I think it's just, as one of the, as Chris pointed out, once you have peer review literature out there, that helps a lot. What I would say that one aspect to do is to keep going back with them with the growing literature in this area about the benefits of it. And I think that's, that's one of the things that people are naturally skeptical about opening up mental health notes. I think it's an understandable worry and concern. And I think that they need to see that, in fact, actually those fears can be allayed and the worries can be addressed. And just as, Marlene mentioned about, the most important thing is oftentimes one of them is to make sure that whatever you're going to write in your note was communicated to the patient. That's generally, by and large, what patients don't want to see. They don't want to feel ambushed by something that was a surprise. So the more we treat people respectfully and as if they can handle things, the better off they are. But I think the literature is actually part of what helps a lot of folks to kind of move the dial in terms of faculty and other folks that are physicians. They need to see that.
And one quick follow-up, a point of reference was that when we, the summer before, we actually started allowing patients to go to MyChart to get PDFs of their chart. I think a lot of you probably have that if you have Epic, but we were amazed, like every month 1,000 people would download their charts, would get their charts. So that actually helped me when docs were like, no, I don't want to share my notes, especially, we do actually have some psychiatrists that share their notes here. And, as long as if the note's not sensitive, it's going to be released when they do the release of records. So I think that's, excuse me, something important to keep in mind is that patients currently can get those notes. And so if you kind of use that when you're talking with people, that helped me talk with people.
I'm curious if, so a person who works for OpenNotes, who also is a co-chair of the California OpenNotes Consortium, I'm very aware whenever a new publication comes out about research around OpenNotes in a variety of aspects. Steve even mentioned he called it the recent article by Steve Jobshaw. None of you probably know what that means. Steve Jobshaw from the VA did a paper about opening up mental health notes in the VA. And I'm curious if this group would find it helpful if whenever a new paper comes out, I just send a 3-sentence email with a link to the article, or I'm just concerned about over-emailing you all, but it might be helpful for you to know that there's new papers out there. So that's just a thing for folks to think about, and let me know in the chat if that's helpful.
And he has about 5 or 6 articles out now at this point.
Yeah, we're getting towards the end of our time. Any last burning questions before we add some headlines?
Hey, this is John Sadek. Could I make a comment?
Please do.
Sure, John.
Yeah, things on the mental health issue. Those of you who have Cerner, and have delayed mental health have a challenge because when you add any other notes to be shared, it goes back to the start date. I actually just heard today from a Cerner organization who has been lobbying Cerner to change that, that they're now getting some willingness by Cerner to change that, so there's opening those notes won't go retroactive, which is a big problem. So those of you with Cerner, I think, could continue to lobby them to enable some flexibility around that start date issue. The other aspect is just an anecdote. A colleague was telling me about a conference they were at, and the topic of open notes came up, and a questioner asked, well, what should we do about the mental health? At the University of Michigan, they included mental health notes, and the chief of psychiatry was there and spoke up and basically said, we included mental health notes right from the start, and that's because we thought to not do so was stigmatizing mental health. I think in some respects it may be time for some of us to be a bit more aggressive with the mental health community and confront them a bit about what they're doing that stigmatizes their patients.
Thanks, John. So we have 3 minutes left, and before all of you start dropping off, we hear a ton of ping, ping, pings. Just know, yes, we will be sending a link to the recording. We will be sending a link to download the PDF of the slides, as well as resources mentioned on this call. I want to quickly mention 3 things that are unrelated to this presentation. First slide, we had a new paper, we're calling this breaking news. New paper came out from Virginia and Commonwealth University, where they kind of conducted their own open notes research about what happens when patients read their notes. It's really exciting, interesting, and I will make sure you guys get a link to this. Next slide. What is my next slide? Oh, we want to mention that Rochester, New York has 2 competing health systems that are huge, and they decided to partner to roll out open notes together at the same time. Sometimes the patients receive care at both places, sometimes not, but these 2 competitors made this a big thing. So they're the first community-wide implementation of open notes that we've seen before. Though I would say San Diego and LA area are kind of getting close since there are a lot of folks sharing notes. Next slide. I just want to, for those of you who might be policy nerds, go look for this. It's the state of California released, the Office of Planning and Research released a precision medicine action plan for California. And it specifically, click next, the action plan makes this huge recommendation that to require vendors who are serving those in California to provide imaging and clinical notes to patients, i.e. open notes. And so just thought that was interesting, and I'll send a link out to this report as well, especially for those of you at cancer centers or doing anything around precision medicine, you might find this interesting. And then I think the next slide is just to remind you, we have our next call coming up either late March or early April, and what's going to be different about this call is it's going to be a little less presentation heavy and spend a lot more time on this Q&A period. So please contact me, please email me if you would like to present something, or maybe even use this as an opportunity to ask the community what struggles are you dealing with so we can learn from each other. Because Open Notes is all about culture change, and you guys are changing culture, so for the rest of us, patients like me can benefit in some way and actually have access to our health information. And Carrie, I'm not sure if there's anything you wanted to say at the end here, but I just want to say, I just remind you all of the words that I got to read earlier from Leah and how important this is for patients like her. Yeah, and that's our contact information. Carrie and I tend to stick around a few minutes after as you jump off, but if anyone else would like to ask more questions, we'll be here. So thank you all for joining us today. Thank you to our presenters for presenting.
Thanks, Liz, for setting this up.
Of course, thank you.
Thanks, everyone.
Thanks, Steve.
Hi, Steve.
The mass exodus of WebEx. Beep, boop,
Are
beep,
you
boop.
counting the beeps?
Terry, it's Gil Stroll, and hi, Liz.
Hey.
Hi,
Bill.
Hi, I just enjoyed the meeting today, and also wanted to just comment that I recently had a chance to speak with several leaders in EPMG, Northern Cal, Kaiser Med Group, and never received as, unfortunately, negative a response to anything I recommended or just linked them to as with this. So it's frustrating. So I was wondering if you have any suggestions, and or if you have at least maybe 5 recent peer review articles that you could share with me that I could share with them.
Yeah. Yeah, to put a package together for you, Bill, with those articles. And then I don't know if this is helpful or if it's something you might, well, I feel like I should let Carrie talk because you guys are colleagues at Kaiser. But in Marlene and Chris's presentation, they talked about the concept of bringing some folks to OpenNotes to their leadership to make a presentation. I don't know if that would help Kaiser in some way, but we could pull something like that together if you think it would help make a difference.
I think at some point that would be helpful because I haven't gotten very far. I've just basically been told that senior leaders know about this. They are not interested. They consider the hornet's nest. And so I don't know what to do with that, except to say that I'm disappointed and share good peer-reviewed information.
But I know other big organizations refused until they changed their mind and are now embracing it. So it's just a matter of they haven't changed over yet. And, the world's moving in that direction. So we will get those hornets addressed. And
exactly. Well, that's my goal before I retire. But I mean, in fairness, I was also told there's a lot of other things on their plate right now. The timing isn't right. There's a lot of things on physicians' plates. And I tried to say, but this is not as big a deal as you think it is. It's just not. It's a win-win. But I couldn't really get past that first set of reactions.
It is going to happen. It's just a question of when. That's all.
Bill, there's a couple of patient advocates who are Kaiser NorCal patient advocates that actually were on this call for a good chunk of the call, who are on the call because they want access to their notes. Some receive care in 2 places and can see their notes at Stanford. Some can see their notes at Sutter and Sacramento area, but don't have access to their notes elsewhere. And so, I don't know if it'd be helpful for them to hear from, the OpenNotes folks on the academic side or from patient advocates and what the right strategy is, because it seems to be different everywhere. Every culture is different.
Well, I would imagine if they were half as articulate as the person whose note you read earlier today, and they addressed that to some senior leaders in Northern California, that could be very influential. They
are rock stars.
I would imagine if they're interested in this.
The top KP leader, has done a lot in the organization. So it's just a matter of keeping it up and persisting and not giving up.
Yeah.
Yeah.
I noticed there's a couple other folks who may either still be on the call or just they haven't closed their computers. And I wasn't sure if Shoba or others are on that wanted to ask questions as well. Maybe not, but I just thought I'd ask. Okay, we can continue chatting.
Run to the bathroom. Yeah.
Yeah.
Yeah, I see some good friends on the call.
Absolutely.
And Liz, so it looks like I'm going to be flying on March 26th.
Right. We'll figure it out.
Yeah.
Hey, Liz.
Yes.
Oh, hi. Sorry, I didn't realize I was still on mute. I just wanted to see if any of the presenters were still on the call, could talk about any challenges with the pediatric population in kind of getting buy-in with things, or any challenges after the fact.
Let's see. So on this call, I'm not sure if John Santa is still around. He's our director of research dissemination and has talked to pretty much every children's hospital in the country. John, are you still on? If he's not, yes, John? No. Okay.
Looks like he dropped off his audio.
Oh, no worries.
Okay. And then I do, well, one. What's that, Carrie?
Is this Shoba?
Yes.
Shobha, we could connect you directly with others, kind of like we were doing around the mental health space, and be happy to do that. Actually, did you get to talk with Chetan Sarabu at Stanford Children's?
Yes, I did when we all met here in San Francisco. So we talked. Yes, I did. I just wanted to hear any other additional anecdotes or anything people had, but it sounds like no one has had any major issues.
No.
Did you see from Deb some information from OpenNotes organization about pediatric? She sent
I think Steph is on the question.
Oh, yes. I'll get to Steph in a second while we're
Yeah, that's okay. You should finish up.
Oh, not sure who I'm responding to now. So yeah, Shobha, I'll make sure you're connected with more folks at Stanford Children's, and then maybe at Rady Children's too, because I don't think you.
Yeah, I talked to them when we all met. Yeah. I just was curious if anyone was still on the line, just of any anecdotal experiences. But I did talk to Chetan, and then I talked with the CMIO at Rady's, and yeah, she was great. Yeah.
I think folks are like, well, hasn't someone had a problem? Tell me the one.
Yeah, that's what I'm looking for. Yes, exactly.
And honestly,
I haven't found one yet, but
yeah. Have you talked with Fabienne Bourgeois at Boston Children's?
I read the paper that everyone's been sending around.
Okay.
All
right.
But I haven't spoken with him directly.
You have officially spoken with everyone. I know that Seattle Children's is in the process of about to go open, and so I think folks might like to, kind of like a Gil's presentation today. He was a more recent OpenNoter, and so it's like if someone's going to have something wild go down, it's got to be a new person. And Gil's like, yeah, things are cool. All is going well.
Right.
Maybe I could do an email, like I could check with the Seattle Children's folks and see where they're at. It could be they've launched and haven't told us about it, which is quite common. And then we're just waiting for them to follow up with us. So I'll just find out what's going on at Seattle Children's, and if there's anything, I'll let you know. Otherwise, and if there isn't anything, I'll let you know. Either way, I'll let you know.
That sounds great. Thanks.
Marlene commented that Rady's in San Diego is on because she could see her own kids, not as a clinician, but as a parent.
Yeah, and I talked to the Rady folks. I mean, they're doing adolescent too, which is, I think, separate from the pediatric issue. Like the pediatric, under 11, because they're sort of the proxy population, and then the adolescents. And I've gotten a lot of questions about that, so I'm just curious. But like Liz said, I'm looking, and I haven't found any problems yet.
Will you, when you officially start sharing notes, will you share that story about how you've looked for all the problems and couldn't find any, and then you launched? No.
Yeah, sure. Yeah.
Okay.
Yeah, absolutely. Yeah.
I want to make sure we get to Steph Lee, who's been waiting. Steph, are you still there?
Oh, yeah. Hi, Shobha.
Hi.
So I snuck in the last half hour because I got excused from my other meeting. So I'm sorry if I missed this, but I don't know. So earlier I heard something about like secure notes not being disclosed, like if a patient requests their medical records. Do you know if that applies to sensitive notes?
Oh, so secure notes is a Cerner terminology. So
how is that?
It's just how they've set up their EHR. It's just a note type. It's nothing.
Right.
Yeah.
Do you know if that's the same as like what our sensitive notes would be like? Like would our sensitive notes be screened and not opened to the patient if somebody were to request their medical records?
No, people have access to.
They would still be
their medical records. Yeah.
Okay.
Yeah.
That's one of the arguments against not going to OpenNotes, where people say, well, what about people who have a domestic violence situation or something like that? And unfortunately, right now, an abuser could demand that the victim get their notes, to look for them, and there's no protection there. But you may want to talk to your HHIM committee or information committee. Sometimes there are ways, like it sounds like they have in Keck USC, where there is a level of review. I think at Kaiser Permanente, I think anybody who asks for their records gets them, is my understanding.
Okay.
My understanding too, in talking to these folks, there's no legal barriers to it. Like some people do it out of like courtesy to not put in certain things, but by right they have the right to it. I think legal. I don't think there's any regulation, that allows to withhold or whatever. So,
from a patient experience perspective, because that's mainly what I bring, as a person who's done a full medical records request and who tried to ask for all of my notes when I moved from Kaiser to UC Davis and UCSF, not because I don't like Kaiser, but just I had to because of insurance reasons, what they ask you on that form, which I believe it's pretty much the same form anywhere you go, is they say, what date period do you want you to request your records from which clinician, which aspect. I said I want all the notes from all the providers. And then, but I didn't specifically call out like any mental health experiences, so I never got those notes. So I think these forms are they're designed as such, you have to be very specific. And so if somebody's saying I want my medical notes, but doesn't call out, say, like a mental health aspect of their notes, we just don't get them unless we specifically ask for them. So I think if the concern is, what if they read the notes, oh my goodness, and then, oh my gosh, what if they do a medical records request? They would really have to ask for those specific things. So you're dealing with like a really rare person who's going to go and dig down deep. And
I want my secure notes only. Right?
Yeah, like I'm looking for those secure notes that were hidden from me that I had no idea were ever hidden. We wouldn't know to ask.
Yeah.
Got it.
All right, I've got to step off now to another meeting, but
you're busy?
Thanks so much, Liz.
Okay. Thanks everyone who stuck around for the bonus.
Thank you guys.
Bye. And
bye.
Bye. And Amanda, thank you.
Yes, Amanda.
Thanks. All right. I'll leave this call now. Finally. Bye.
Okay.